A very good morning to everybody. So, for the past 2 days, we've had several interesting panels over a range of themes and ideas. Today, we start the third day of the ninth Creative Theory Colloquium 2022, organized by the Creative Theory Association in collaboration with the International Herbert Marcuse Society, the Raza Foundation, and the India International Center, with a very interesting panel on the future of public health. So I invite the coordinator for the session, Priyanka Yadav, who is a research scholar at the Center for Political Studies, Jawaharlal Nehru University, to introduce our distinguished panelists for the day, along with a briefing to the theme of the session.
Thank you, Bindiya. Thank you so much. So, yes, I welcome you all for this ninth Creative Theory Colloquium and to this wonderful panel, which is known as the Future of Public Health. When we talk about future, health is something that is thought of very immediately or by default, especially when we as a community and humanity at large have suffered because of the global pandemic. Having said that, it becomes all the more important to discuss future possibilities of public health in an organized, sensitive, and a critical manner. Therefore, we bring forward our esteemed panel whose insight in this domain can bring rational thinking and inform us about the various progress or perhaps the kind of things which can help uplift the public health sector in future. So I welcome the chair first. So our chair for today's session is Mr. Chandrakant Lahariya. He is a leading medical doctor, infectious diseases and preventive medicine specialist, child health and vaccine expert. He has worked with WHO and he publishes regularly in medical journals. Our first speaker for today's session is Dr. Ritu Mehrotra. She's a professor at the Center of Social Medicine and Community Health, School of Social Sciences, JNU. She has also worked as an advisor at the National Health System Resource Center. Her area of interest and specialization include nutrition and health, urban planning and health, public policy formulation and analysis. Our second speaker for this session is Dr. Vikas Bajpai, who is an assistant professor at the Center for Social Medicine and Community Health, School of Social Sciences, JNU. Previously, he worked as a public health physician in Delhi. He has experience in working with trade unions, youth, and women organizations on health issues of the underprivileged. I welcome all three of you. And now I hand over the baton to the chair to give his introductory remark. And after that, we begin the session. Just to note down, we are giving 20 minutes each to the speaker to speak. And we would like to request to stick to the timeline. So thank you so much. And Mr. Lahariya, over to you.
Thank you very much, Priyanka ji, and good morning. Good morning, esteemed panelists, colleagues who have joined here. It's indeed a pleasure to be here and discuss with such an eminent panel about the future of public health. I've received an agenda or program flow, so to say, so I'll speak for a few minutes and then I'll invite the panelists who will speak, who are requested to speak for 20 minutes each. And then that will leave some time for discussion and we will have a follow-up discussion, more of a dialogue style, and then we will close by 11 a.m. So that's the plan. I'm aware that my fellow panelists have a much more to share, but let me set the background for the future of public health this session. And what could be the critical reflections? So one of the things which I recall, and the Nobel laureate Angus Deaton, he won Nobel Prize in 2015 for economics in his book, The Great Escape, Health, Wealth, and Origin of Inequality, has reflected about health. And one of the discourse he has in his book, he says that much of the development, which include economic as well as social development in some of the high income countries happened in the last 2 centuries, attributable to what they did and how they followed up after the previous two pandemics. So Angus Deaton writes in that book that after cholera pandemic, which started in 1817, there were seven cholera pandemics over last 150 years, but 1817 onward, the cholera pandemic, first two pandemics, 1817 onward, and then 1830, 1840s, resulted in the great sanitary movement, the International Sanitary Conference, stage all this thing. So he argued, and that is a fact, that that cholera pandemic resulted in the development or progress of public health across the world. So that was one major development, and which today we are talking about public health, but much of the public health movement started in mid of the 19th century after cholera pandemic. Of course, the plague pandemics and of 14th century onward, there was a lot of attention on public health, but not that kind of global coordinated attention. So that was one aspect. Second, Angus Deaton argued that after flu pandemic, the similar developments happened, but much of the development was focused on medical care, treatment, antibiotics, and others. So medical advancement happened. Argument, because in the modern society, the argument always centered around economic development rather than social, or social developments come, but they come at the later stage. So economic. So Angus Deaton argued as an economist that much of the development, what we see in economic development growth, which we see in Europe, happened after the two pandemics and what countries did. And now the countries which are high income countries or upper middle income countries, they followed strengthening public health, improving health services, investment in the health services in those nations, also providing free cares or the models of the care. And that's how much of the economy grew, and attributed the growth of those countries attributable in a sense to the pandemics of the past. Now we are in the 21st century, 2.5 years into the COVID-19 pandemic. What would be the key actions which would be taken by different nations after this pandemic? That's difficult to predict. But what we know, that even with the previous two pandemics, the low and middle income countries did not pay sufficient attention, did not follow through with the sufficient attention to improve health in those nations. So it is not given that pandemic automatically results in improved increased investment by the governments on health. But I want to bring another dimension, and that is between there are few studies which have emerged, and now we know that in addition to the pandemic is not the only challenge. We know that emerging and re-emerging diseases are going to be another challenge. And we also know, the Wellcome Trust has studied and other group have studied, that between 1940 and year 2004, around 350 pathogens or the viruses and bacteria, different pathogens had emerged, which are able to cause disease in human beings. Out of those 350 pathogens, around 2/3 of those pathogens emerge from the forests or animals to the human being, the zoonotic in origin. So that is going to be another challenge. Third dimension, we have seen in the past, and we have seen in this COVID-19 pandemic, the inequality. Though the medical advancement or public health movements have happened, but they have widened inequity. The majority of access to the therapies, interventions, and health services in high-income countries. The low and middle-income countries rarely have that kind of access, and this is not this inequality is not reducing but widening. We have seen this in the access to vaccine, COVID-19 vaccines and therapies, and with monkeypox also, that this is not altering or changing. So keeping all these things in mind, that pandemics bring change, but it is not automatic. Countries need to act upon it. Zoonotic diseases are emerging. The studies which I said that 200 or 2/3 of the diseases are zoonotic, a very recent study published in Nature on 20th of April have said that if a global temperature increase between now till 2070, between 1 degree Celsius, it may result in at least 15,000 additional pathogens emerging in the human population, and some of them can cause disease. That study say that those pathogens would mostly emerge in Asia and Africa, which essentially means the risk of new diseases, the new challenges is more common for Asia and Africa, where the health services are weak, which always face the excess in the various intervention which should be made available for to tackle such challenges. I would summarize my point and then hand over to my colleagues with this background. What we know that pandemics bring changes, but they do not bring positive changes in the settings where they should be brought. Pandemics, every passing day, we are reaching closer to the next epidemic, outbreaks, and pandemic because of the deforestation, climate change, urbanization, rapid transport, antimicrobial resistance, single animal battery farming, our preference for a wild animal meat. So there are many factors which are resulting in ensuring that next day or today we are closer to the next epidemic outbreak than yesterday. And inequality, nothing systematically being done. And final point is that though in the last 2 years, 2.5 years, we heard a lot about public health or strengthening public health, but if we reflect now, the discussion or discourse on public strengthening health system or public health was very superficial without sufficient understanding, and even that is being forgotten at the level of government. It is the right time to discuss future of public health. And with this, I would like to invite the panelists for this session. And let me check. As per my list, the first panelist whom I would like to invite is Dr. Ritu Priya. Priyanka has already introduced Dr. Ritu Priya, and so she does not need any introduction. So over to you, Dr. Ritu Priya.
Thank you, Dr. Chandrakant, and thank you for laying out the broad scenario of what are the challenges to the public health that we are facing now at this time, because that is what we would intend to address. What I will do is take that as a given, which you have already presented, and talk about in the 20 minutes that I have, about how public health as a discipline needs to introspect and think about where it needs to go forward in the way we think about public health and about what we do. So I just titled this talk, The Future of Public Health Between Authoritarian Tendencies and Liberative Potential. As you referred to the industrial towns of Europe, and that being the origin of the present institutionalized form of public health that we have, we clearly have this historical legacy. And we'll have to go back to that and to understand that to take us forward. That's my understanding of any knowledge processes. And I think public health will have to go back to that. But what we face right now are both external and internal crises. And I will attempt to place how I diagnose this present crisis. The historical legacy that we have since public health's institutionalized development in the 19th century clearly states these two: the authoritarian tendencies which we see in the way the European towns started with something called the health police, which was meant to ensure that there was hygienic behavior of the migrant working class that came into the industrial towns of that time. So that was one element in public health. And the other was the issue of John Snow showing us how the environmental conditions are important and therefore led to urban infrastructure and public health being developed. And the third stream was of something like Angels telling us about conditions of the working class at that time, and thereby leading to labor rights, labor laws, and improving the conditions of work of the workers. So these are three dimensions of public health, all of which is evident right through our history. And what we need to see is what kind of academic work contributed to which of the streams, and therefore how do we in today's time contribute to the liberative potential that public health clearly has. So I will briefly attempt to do that. I'm very hesitant in an audience of social scientists trying to place views of this nature, but let me still go ahead and place what, looking for feedback and inputs to take this kind of a discussion forward. I place these three streams before you. The authoritarian, the environmental, and the, let's say, the bottom-up conditions of life approach, or the social determinants approach. And what we see in all three frames of that time and over the 2 centuries that we have, the 19th and 20th, are centralized systems with universal solutions. A colonial dichotomy in their practice. While we had the sanitary movement in the colonizer countries, the others certainly got the brunt of it. And therefore, the practice of public health has these dichotomies as much as a centralized perspective. And I would place the centralized perspective and knowledge frame as part of the reason for the dichotomization. Post-independence, the welfare states in the ex-colonized countries developed their health systems, but they tended to emulate those of the first world or their colonizers and dichotomize them from the popular everyday practice in their own countries and any other epistemological traditions that existed in their own countries. This continues, this dichotomy between the state provisioning and its legitimization of what therefore becomes the formal system, whether of modern science or of other traditions of health sciences and health knowledge. Studies conducted, for example, in Delhi in 2014-15 show that the formal services deal only with about 33% of illnesses in Delhi in 2014-15 across various sections and classes. So this is what we have seen as the development of public health. The roots of the knowledge paradigm is clearly in the positivist biomedicine and demography. But subsequently, there has been a major progressive movement with social sciences and the realist paradigm being introduced at various points of time. And all those points of time have been points of larger societal crises. Whether it was in the industrial towns of Europe in the 19th century, where it could not be just pure biomedical. There wasn't enough knowledge of biomedicine, but also there was an eco-social kind of approach. What we call eco-social today was evident in the way studies were done at that point of time. But as now very consciously we bring in the realist paradigm and the contextual needs, we do so in the post-independence, we do that in 1970s when there is upheaval across the world. We do that when the HIV pandemic comes. Now in the 21st century with escalating inequalities in access to services and technologies and unaffordable medical bills, even for the first world, highlighted by the 2008 recession, the knowledge base includes these interdisciplinarity and social sciences and realist approaches. And yet we seem to keep harking back to the positivist. And we have the knowledge base supporting the authoritarian tendencies today in terms of the continuity of reductionist approaches, which attempt to modernize themselves at this point of time. And so, for example, you have the World Bank epidemiologists and economists creating a database using something, statistical tool that they devise called the disability adjusted life years. And that becomes the basis for quantifying ill health and disease across the world, including in India. and it is used for prioritization of funds. And there's enough analysis to show how it skews the priorities. Now in the 21st century, there are three threats that I'd like to highlight. There is the external threat from a highly medicalized vision of healthcare. And so when we have a slogan like universal healthcare for the SDGs or for health development at large put out by WHO and UNICEF, it is about universal health coverage with medical care funded by insurance. Thereby, public health gets relegated very much to the background. Second is the heightening of authoritarian tendencies in keeping with political and economic ethos of the time. And there, public health gets called upon, as in COVID, positing options of lockdown as against well-being and economics. So it becomes public health versus well-being and economic development, rather than the three being seen as conjoined and together. And the third is a process of reconfiguring of the identity of the field itself, which is coming from internal to the field or internal to the academic sphere. From public health, we are tending to use more and more the term global health, with some discourse incorporated of decolonization of knowledge, which, if you look at the journals and do a review of the authors as well as the titles, you'll find global health replacing public health perspectives and an attempt at decolonization by bringing in researchers from the LMICs. But in most of the discourse, those who get published are the ones who are not questioning the content, the ontology, and the episteme of the positivist roots of the discipline, or questioning biomedicine. That's the dominant mainstream of public health. We see that also in, for example, the way policymakers pick up the more easy technocratic solutions. And what is recognized by the high polloi of the world today, where the Nobel Prize given to development economists like Abhijit Banerjee and Duflo are for something which they do call the randomized controlled trials for health, including for health programs. And so that is what is recognized as legitimate evidence for public health policy and programs, and not the social determinants of health, the issues of eco-social dimensions, of embodiment, of social location, and of issues of economics, livelihood, culture, of different epistemologies coming into the mainstream of what is health systems research, while the contingencies of demand and of local politics on the ground does make WHO and national governments take cognizance of and also promote the development of other epistemological traditions like traditional medicine. But the two don't talk to each other. Health systems, development and research, and the traditional medicine streams within WHO as well remain wide apart. And we see that in the entire public health discourse, where there is, if anything, a mocking of the other epistemologies as we saw during COVID, rather than attempting to incorporate, even while we talk of realist approaches and diversity of perspectives being important. So this kind of framing we see in epidemiology and in health systems research, while at the same time, we do have strands which are attempting to take these into account, and I'll talk about them briefly later. Now, in this kind of a context, what the global means here is, and moving to global health, why I call it seemingly regressive to the liberative potential, is because it is even more centralizing. It is tending to blur the contextual differences between the high-income countries and the LMICs in terms of health problems, and health priorities, because it is doing a global analysis and creating global priorities. And its tools like the tallies that I referred to blur all this in the name of equity and an inclusiveness of all at the same level, putting everything on one platform. What I would now like to move to, with this kind of a political economy of the crisis and a politics of knowledge of the crisis, how can we as an academic stream, where we are talking of future of thinking, contribute to the liberative potential? And our contribution, I would see, would have to be through a transformation of the knowledge framings, especially for health systems research, policy planning, and implementation. That's where we see the impact of the kind of academics we do. The two broad approaches that I just mentioned, one, the biomedical disease and technological intervention focused approach, which claims universal applicability, and the other, a more ecological, socially oriented, and contextually rooted approach, are with us today. There has been a great advancement in the ecological, socially oriented, and contextually rooted approach. And yet, every time policymakers have to take decisions, and especially in times of crisis, the justification immediately becomes, we have to fall back on science. And the notion of science still continues to be the same reductionist, technocentric, and with solutions that can be applied at a technocratic level. So how do we move out of this notion of science, which underlies how public health gets addressed, is to me one way in which we can contribute to moving towards a more liberative potential, even in these times. Because the crises that face those in power do have their own contingencies, and they have to, at some point, as history shows us, take up solutions which may be outside the immediate technocratic and outside their managerial ken, and give them some space. So can we start making those spaces? But first, I think we need to do a bit of introspection on how public health professionals themselves are thinking about public health, even among those who are placing themselves, locating themselves with the liberative potential of public health, as it naturally contributes to the needs of the more marginalized, because they are the ones with the greater health problems. In doing this, there has the fragmentation within that I spoke of. The fact that today epidemiology and its more cutting edge policy oriented epidemiology is being done by mathematicians and statisticians in departments of mathematics and statistics who have little grounding in public health. Example of that is the what we saw again during COVID, the Imperial College giving us the graph which shows us that only if you close down social and economic activity and thereby the lockdown comes, that you will prevent deaths and so on, is where we have allowed ourselves to go when we allow public health to specialize in such ways that we have epidemiology as becoming a separate field, HSR as a separate field, health education as a third field, rather than an integrated public health perspective, which is what we, even the likes of me, have been taught to practice. And it's in the last few decades that this dichotomization of and fragmentation of the discipline has become very evident. It's also because we have so many disciplines. It is by definition a synthesizing science, and we draw from many disciplines, and therefore a kind of fragmentation is there in the intellectual content. I've just looked at my clock and I think I will need to close very soon. So I'm going to now move to saying that what I'm suggesting in this whole sphere of fragmentation, which allows for the more reductionist technocratic approaches to take over, we provide them that possibility. If we move to what many other disciplines like the sustainability sciences and science and technology studies are doing much more than we are in the sphere of public health, is to move to much more holistic approaches. And I'm not talking about the holism only of the traditional sciences, which is where medicine tends to see holism, but look at something called critical holism. Holism, which brings in a contextualized, multi-level, multi-dimensional approach and the multi-dimensional conceptualization of health and its causality. Thereby, this is the ontological approach, realist and historical analyses being the epistemological approach that one would have to take for critical holism, but tending to go beyond the realist, because as we see in reviews of realist use in public health, the historical analyses, epidemiological base, the diversity of context of the whole, and pluralist epistemologies are all missing even in the mainstream realist studies and stream of public health. And therefore, we need to posit some kind of a larger unifying theoretical framing, which will be able to provide a space where all these various streams can talk to each other and have a common framing, which is not to say we don't need these specializations. We do, and it does provide benefits. But can they talk to each other? Can they dialogue to each other, with each other, and thereby give us more comprehensive understandings of the problem as well as of the possible solutions? This would require going beyond the positivist to allow for contextualized and diverse approaches, interdisciplinarity, move to transdisciplinarity, which means incorporating not only different disciplines, academic disciplines, but incorporating non-academics in the research team with their specific epistemological frames. This requires recognizing the validity of layperson understandings and their diversity, recognizing the validity of other knowledge traditions, and an intellectual ethos that encourages dialogue across all these grids. Now, at this point of time, this may be asking for too much, but certainly I would posit that those who are looking for liberative potential in public health need to make this attempt at a leap forward. It's a leap which needs to be made for us to be able to think from a bottom-up perspective. And we have a lot of support for that in the current developments in the knowledge sphere, complexity theory certainly being one, but there is a whole range that exists. Yes, Priyanka? I need to wind up?
Yes, ma'am.
Yeah, I will. Just give me 2 minutes.
Yes.
Is that okay? Yeah. So I'm positing this as a unifying theory, and one can see how, if one looks at, for example, the primary healthcare document of Alma-Ata, which is what we keep going back to, and the world did in 2018 in the Astana Declaration as well, it also asks for more inputs for us to think of something like a primary healthcare 2.0 for the 21st century. There are other sources for something called critical holism in the way we can think about public health, but I'll stop here and take questions, and maybe there's other readings that we.
Thank you very much, Dr. Ritu Priya. So a lot of reflections. I would not try to summarize those, but one of the key point which I would say is core. There are many points. It's challenging to summarize. So I would say that one of the points which you highlighted about integrated public health and the reflections on public health, economic well-being, and growth and development being seen as a conjoint rather than in isolation, some of the challenges which you have highlighted. You reflected about global health. We will take questions and a discussion on this topic after the second talk. So without further ado, I'll invite Dr. Vikas Bajpai to share his reflections in next 20 minutes. And then we will have a discussion, and then we'll open this for a question by the other participants and audience.
Thank you, Dr. Lahariya, for giving this opportunity. Thanks to other organizers who opportunity to share some of them. I was also not very sure to begin with as to what aspects need I here, given the kind of audience which we will have. But I think going by the concept note of the colloquium that I got, I'd like to focus on certain things which I think are a priority. To begin with, what is the future of public health? I mean, it's like saying, also asking, what is the future of mankind? And people of my want or my kind of background, we feel obligated always to believe and say that the future is bright, only that it faces a lot many challenges, and need therefore of our being able to negotiate those challenges successfully. So now the thing is, what all impacts on public health? Well, I teach to my students public health is impacts public health, including the sound health. Okay. So, but unfortunately, in so the paradigm in public health policy or the is that of missing goods for the trees, and increasingly what I find is that even the trees that we cite, we are more interested in chopping them down rather than nurturing those trees, given the overall policy paradigm as it has come to exist, not just in India, but across the globe, and is being enforced with in many ways. But the good thing is that while they do so, resistance is also on for all of this. Now, there are the question is of how do we identify the challenges, okay, and then how do we fight those challenges? So I will not go into the entire breadth of these are still bring out certain points or certain things for aspects for consideration by the learned. And see, I think when we talk of challenges, we must keep in mind that the society builds its institutions in, okay, may it be health institutions, may it be educational institutions, or institutions of economics and various other kinds. So what is the reality of our society? See, this reality of our society is, it is a caste divided society, where fault lines also exist along the lines of religion and ethnicity and regions and all those kind of things. And given the situation as it is, I mean, it is not that we are making attempts to remove these fault lines, to bridge them, to heal them, but rather the politics and economy and social system, it seems to feed on these fault lines, and it seeks to broaden them, deepen them, to privilege the power structures and the powers that be. So if that is the situation, then it becomes given that our health system also reflects these inequalities, these divisions. Unfortunately, what happens is that we do acknowledge the inequalities and divisions and the discriminatory nature of health services and all, but we do so in very, very mechanistic way, that okay, this is a problem, so now what is the policy patch that we can put on it to take care of the problem, without really tracing the social political origins of these deficiencies, which are part and parcel of our health systems. Okay, so you would have a policy of public-private partnerships, okay, to make health more accessible and reachable to the marginalized. We then have now this state-funded health insurance schemes, and all these things are brought into play. But then we find that by experience that this is not quite yielded the kind of solutions that we need. Now, when I said this malady of a problem of not being able to see the social, political, economic roots of the divisions that are interladen in our health systems, in our health services systems. This phenomenon, it plays out at different levels. It plays out at the level of policy and the government and institutions. It plays out at the level of individual institutions that constitute health services system or health system. And then it plays out at the level of the people who work in these systems, okay, their own orientation towards the people whom they are supposed to serve. And lastly, it plays out at the level of the societies. Now, the thing is, if we identify these, the problems at these 3 or 4 levels, then the prospects of correcting these have to be studied at all these levels. And what is the situation as to that? Now, insofar as health policy paradigm is concerned, I will not go very far, but let us begin from 47 onwards. Okay. Now, in 46, we had this report by Sir Joseph Bohr, which we popularly known as Bohr Committee report, which actually laid down the foundation for the development of health services system or health system in India, not just health services system, health system. And when I say health services, health system, it implies that health was seen as part and parcel of the way economy was to be structured, the way industry was to develop, the way agriculture was to develop, and various other parameters or which impact on health. So Bore Committee laid out a very elaborate plan, and in which they consciously asserted that even though we've been tasked to only lay out a plan of a scheme for the development of health of the people, but I think, we think we will be, we will not be fulfilling our task if we were not to make broad recommendations about economy, about agriculture, about industry, about various other aspects, which are essential to making of health of the people. And that is one report which in in traditional or not traditional, what shall I say, for want of better word, a holistic conceptualization, people who believe in holistic conceptualization of public health, they still like to go back to that report and talk about it and the way it prescribed. But then that report had come in the background of certain developments which were taking place at that time in the world. And what were the developments? The developments were that after World War II, Soviet Union had emerged as a superpower. That is the first socialist state where working class was in power, was now in contention at the level of the world politics, world arena, and lot many other countries also became socialist. Even in the Western countries, there was a powerful and a vigorous movement of the working classes. In Britain itself, Labour Party had come to power, and the then Prime Minister Clement Attlee, he took floor in the Parliament, and from the floor of the Parliament, he declared, "Ours is going to be a socialist government." These were his words, a far cry from what Labour is today in Britain. But then, and there was a whole set of policy paradigm about public health housing, about removing illiteracy, about joblessness. And in that policy framework, health was a part of it. So somehow these developments, they recognized the interminable link between health and all the other aspects which go into creating conditions for wholesome development of humans, of human life itself, imparting dignity to it. Unfortunately, in India, while we did have a political independence of sorts, but certainly that had failed to change the way Indian society was constructed. We had a very modernist constitution overlaid upon a social firmament which was quite feudal in its orientation. Okay, not feudal in the classical sense of the Middle Ages and all, but still its orientations. We retained our caste system and have, even after 75 years, we now, even those in power, they talk of its virtues rather than talking of removing it or working towards obliteration of caste. So we had this situation, and hence the class interests which were at play in the society at large, they were bound to impact on the way we developed our health services system also, our health system as such. Likewise, all other systems, but since we are on the topic of health, I'll concentrate on health. See, Bore Committee said that 15% of all government expenditure should be on health. And in the very first 5-year plan, all that we managed to allocate was about 5% to health. Okay. And in subsequent plans, it came down even lower than that. So that has been the trajectory. But then, given the way international scene was, it was a time of Cold War and there was a socialist camp and all. There was also this fact that at the time when we gained independence, India's own big capitalists, they hardly had the financial muscle to be able to build the kind of health institutions, tertiary care hospitals, medical colleges and all, which were very much required, because for them to be able to have healthy workers, healthy working people to work in the industry and all. So likewise, now it was requested to the government to build all this infrastructure. And hence, we find that the emphasis which came was not in terms of reaching out healthcare expeditiously to meet the immense health problems which were there at the level of the people, that is by strengthening the sub-centers or primary health centers or those peripheral healthcare institutions. The emphasis to begin with was on building big hospitals, medical college hospitals and all. Okay. Anyways, going into all of that history will take very long. So I to the present phase of neoliberalism. I don't even go into the entire history of what neoliberalism did to health culture and health sector in India. But without having to add my own words, the National Health Policy 2017, you should read its draft version which came. You know, when neoliberalism, neoliberal policies were openly acclaimed and were peddled to the people at large as that they will provide succor and they will develop us and all that. The push towards corporate hospitals and big private sector, it was not just supported by the state, Apollo being the example. There are hundreds and thousands of others where public resources were made available to these private players and all. But it was said that this will bring world-class healthcare to the people here in India on their doorsteps, you know, and arrangements like providing free care to the poor and all those kind of things were made. 2017 policy in its draft version, it stated that all this private sector, they should be exempt from the encumbrance of taking care of the poor. Okay, because they are contributing to the growth of the national economy by their contribution to the GDP. And they do an active advocacy for by the contribution to GDP through medical tourism. So, keeping in mind the country that we are, where government's own policy establishment, Vivek Debroy, in a recent paper said only barely 10% of Indians earn rupees 25,000 or more per month. Okay, given those realities, here we have a government. And mind you, this is not just BJP government. The policy, National Health Policy 2017 had been in the making since the time of the UPA government. Its draft version was much the creation of the UPA government. So we have this policy document where government says this upfront. Okay, we need not care for them. In fact, prior to that, even in 2001, National Health Policy 2002, it stated the government cannot take care of the poor also, all by itself. So there have to be mechanisms where there is service delivery by the private sectors. Okay, so and those who can spend a little bit, they should be paying for their health. Government itself was washing its hands off. Now, if we come to the institutional, from policy framework to the institutional framework, of course, the way policy is made, it is bound to function, bound to impact the functioning of the institutions itself. Okay, so now given this push towards private sector, privatization, and this emphasis on quote unquote providing world-class healthcare. Now, who decides that what is world-class? What is provided in Massachusetts or in Harvard, that is world-class? Or the simplest of the technologies, the most affordable of the technologies, which can provide relief to the people for the problems that they suffer from, that is world-class. And the choice between the two is colored or guided by our own class orientation, our own class outlook and world outlook. Certainly, in a highly privatized, profit-oriented healthcare, you can be absolutely sure that the world class is something which originates from Harvard, from Massachusetts, not something which is dictated by the needs of the poorest of the poor in our country. Now, this means technology-intensive interventions and cures and treatments. Technology-intensive interventions and cures and treatments, where can they be provided? They will be concentrated, obviously, in large hospitals. Large hospitals, and where? In big cities. Why? Because it is there that the rich are living. Those who can afford to pay for these services are living. The rural rich can always come to the cities. They don't mind.
So 2 minutes.
Sure. Okay. So now you find that with this shift, the shift also happens in the way we treat our doctors, our technicians. Now, a doctor who feels supreme aplomb in reading a CT scan, but may fail to make out a lump or a swelling inside or something by simple techniques of palpation or auscultation and all that. That is what has become, the whole orientation of medical care, medical education has changed. You are producing doctors whose aspirations are very different. And aspirations are different also because now attaining medical education is not the same way as I attained it, by paying mere 400 rupees per year as college fees here in Delhi. Today, lakhs are being spent even before one enters a medical college. And you conduct a survey of all medical graduates in colleges in Delhi itself. Their career path is very, very clear to them. They know that after having cleared first professional, they will take, after having cleared second professional, they will take ECFMG Part 1, which is the exam for the qualifying exam to go to US. After doing their internship, they will take ECFMG Part 2. And thereafter, happily united body and soul in US. They are not even having to think. And then, can we expect the doctors that they will go and serve the people? I just want to highlight one example of what all of this can do to the psyche, to the thinking of our being. You see, in 1992, when Babri Masjid was demolished, I was junior resident doctor at UCMS. and GTB hospital. And many areas around us, there were many Muslim localities and there were riots, of course, you all know that. At that time, we had an organization, Delhi Medicos and Scientists Forum, and we organized a relief work into those rioted areas. We've subsequently brought out a report also, and for which many of us, rather most of us, were hounded by the Home Ministry at that time. But nevertheless, there was a doctor, a class fellow of mine, who was part of that team. He subsequently became a very eminent neurosurgeon. Okay. And he was part of that team which went to those areas providing relief and all. For many years, I had been taking political contribution also from him. But then how things change. I was shocked when during this COVID crisis, migrant crisis, when it happened. And I was having some exchange with my friends and all, him included. And I wrote to him the way people are being made to suffer, and this pandemic is showing us the mirror. So he wrote back, and I quote verbatim, I am in support of the policy decision, that is the decisions for lockdown and all, taken, although they could have given 48 hours to reach wherever anybody wanted to go. You can choose between killing 1 lakh or 10 lakhs or maybe more. No decision or policy could save everyone. I'm not questioning your rationality, but you should also not think that what others are doing is always wrong. Also, when you condemn, tell what should have been done. And I can cite you many such examples. In fact, recently, the Medical Council of Karnataka, it had to issue a proper letter to its members, because many of the doctors in Karnataka, they were found to be propagating communal propaganda and calling for killing of the minorities. That letter is there in public. It's not a secret document. So I think, now what is the way, if I may take just one more minute? I think that apart from framing, of course, there is a role for technology, there is a role for managerial skills, the organization, and all those things. But apart from framing public health in techno-managerial terms, we need to frame public health in social and political terms, very, very categorical. And one of the ways, apart from all the other eminent ways, would be that the public health people, the medical practitioners, medical professionals of various kinds need to be involved in people's trials and travails, their day-to-day struggles. And one example which I can cite was that during last farmers' agitation, we, on behalf of Progressive Medicals and Scientists Forum, we organized massive medical relief efforts at all these camps. And I mean, I myself did not believe the kind of response that we'll get from the doctors. There were many who had never been in touch with us earlier and all, but somehow came to know that PMSF is organizing these camps, and they came along. And when last riots took place in Northeast Delhi after CA and RC, PMSF organized a medical relief camp and fact-finding into those areas. And again, we had some wonderful interns coming with us to lend their services and be a part. So I think along with theory, it is the practice of that theory and those theoretical percepts that will pave the path for a brighter future for public health and for all of us. Thank you.